Good evening to all of you. My job today is introducing this new venture of 5AP chapter, and my topic is recognizing a sick child. This is not anything about intensive care, as Shija has said. We are trying to understand the ground reality that there is limitation of facilities, but with the available facilities, what can be done for the best outcome of the child once a child reaches an intensive care unit. So with that, we have made this module. So because this is a TOT session, it is open for criticism and suggestions from the trainers, from the would-be trainers, so that we can change the module accordingly. So my topic is, let me go to the topic. It's recognizing a sick child in a peripheral hospital. So one point that we have to teach them is why is this important that we have to recognize? Why are they not just small adults? Main thing is children don't communicate well themselves, and when we fail to recognize the seriousness of the condition, it can have long-lasting effect on the growing brain of the child. So that is the important point, that why this is important. Okay, for example, like statistics show that the mortality rate was 8.3% within refractory status epilepticus. And there's a neurological deficit in about 25% of the cases if it is not properly managed. And hypoglycemia, infants with repeated episodes of hypoglycemia had significantly reduced head circumferences and lower scores in specific psychometric tests at 3.5 years of age. These are all just, I've put a couple of slides so that people understand the importance of why this is needed rather than just referring as such once you see a child. And in TBI, favorable neurological outcomes had a duration of CPR significantly shorter for those with unfavorable neurological outcomes. So if somebody had a CPR for 4 minutes, it was better than somebody who had a CPR for 23 minutes. So the starting of CPR or avoiding a situation that would lead to a CPR is very important. Okay, and what are the common symptoms of sick child? These are all very basic things for somebody in a peripheral hospital, including nurses or other staff, paramedical staff. So a child with difficulty in breathing, a child with high-grade fever, a child with a rash, which has happened over the last 24-48 hours, child who is having seizures, dehydrated child with abdominal pain, child with head injury. These are all common symptoms of sick children, or who can deteriorate in front of you. And so be alert if there is an ex-preterm who is coming, who are chronically unwell children like cerebral palsy, syndromic children, malnourished children, and children who are less than 1 year of age. We need to be more careful. Okay, so we need to talk to them a little bit about the pediatric assessment triangle. So this pediatric assessment triangle, rather than the pentagon, actually purposefully took the triangle because there are only 2-3 things that people have to be careful about. So we will talk about how the appearance will help, like an abnormal tone, reduce interactiveness, reduce consolability, abnormal look, abnormal speech or cry of the child. So if you see anything of these sort, you have to be careful. And the work of breathing and the circulation, like pallor, mottling, cyanosis. So we need to just get into their minds that these 3 things, CNS, respiration, and CVS, these 3 points have to be taken seriously. And if there is a problem in any of these, that child need to be monitored. Things have to be done, like how we go once we go further into the topics, we'll realize what has to be taught to them. But this is the most important slide, I would say, in this whole program. Okay, so how will a child with respiratory distress present? You have to teach them about grunting, what is ALNA flaring, what is head bobbing, suprasternal retractions, subcostal intercostal retractions, cyanosis, and lethargy. So these are, like, we have to tell them these are the features. And there are a couple of videos which I have included, which will tell them what is it. I'm trying to get the video so that they recognize the upper airway noise, like a stridor or just a snoring. And another one on how the respiratory distress will be. So we have to teach them how a respiratory distress will present, how will a child with paradoxical breathing present, when is this child going in for a respiratory failure. Okay, right. So those are the things in the respiration. So the main thing that we have to get across the table in respiration is how to recognize the respiratory distress when you see the child, especially like in a triad situation. And then we'll go to circulation. So heart rate, rhythm, capillary refill time, pulses, and blood pressure if it is feasible. Right. So what is cyanosis and what is poor perfusion? So this is basically just slides showing how a child with poor perfusion would look like on initial impression, like when you see, and how a child with rashes, and how do you check for the capillary refill time. Okay, so we have to tell them that compensatory mechanisms for altered physiology are robust. So hypotension is a late sign. So we may not see hypotension earlier. And signs of poor perfusion to organs will be a child having tachypnea, reduced urine output, mottled skin, cold peripheries, and altered mental status. So how do they appear if they have an abnormal neurology? Sick children are either irritable, they'll be floppy, or they'll be drowsy. And it is important to look at the pupil size and response to light, because pupils are window to the brain function. And a depressed sensorium is important sign of brain dysfunction, shock, or raised ICP. So in neurology, it is basically a depressed sensorium. Look at the pupil size and whether the child is irritable or floppy. And who is unwell? Any child who responds to stimuli but cannot maintain alertness is lethargic. And any child who is sleepy and reduced response to stimuli has an abnormal neurology. Right. And the posturing, like how does us decorticate and decerebrate posturing? Is it important? Is it something that we have to be worried about? Okay, and we have included a chart for vitals for age. We are planning to print this out, laminate, and then give to all the hospitals. So, okay, so how should they triage? First is any child, when they see, you have to, on your initial impression, if you feel that the child is sick, do the pediatric assessment triangle, and then call for help, attach monitors. Look for the vitals, like in the chart, if it is high or low for the age. Get an IV access and get the defibrillator ready if it is available. Then you go for the ABC approach. Airway, if it is clear, then you can go to step 4. So that is a step 3. Then airway is maintainable, do the head tilt, chin lift. And if it is not maintainable, we'll start with the bag and mask or LMA, basically. Even if they can't intubate, basically LMA. And step 4 is the breathing. So if it is irregular or slow and low saturation, you start bag and mask. If it is fast breathing, then you look for the cause, oxygen, fluids, rule out acidosis. Then you go to circulation, tachycardia, prolonged capillary refill, poor pulses, we'll give fluid bolus, and hypotension is a late sign of shock. We have tried to make it as simple as possible. Okay, and so it is basically teamwork of the primary care and the tertiary care which will lead to a good outcome. So with this, I think that is the end of my presentation.